From Sarasota Memorial and the Deb Kavanaugh Multimedia Studio, this is HealthCast, a healthy dose of information from experts you can trust.
Hi, everybody. Welcome to HealthCast. I'm Allison Gottermeyer. Thank you so much for joining us today as we talk about the diagnosis and management of epilepsy. Our guest today is Dr. Brian Wolf, who is board certified in both neurology and epilepsy. Dr. Wolf, thank you so much for being with us.
Yes, thank you so much for having me today.
Start with the basics. What exactly is epilepsy?
That's a really good question. So I think there's a misconception about what epilepsy is versus what a seizure is. So a lot of people, I think, equate seizure with epilepsy, but in fact, they're very different. So a seizure is actually, in colloquial terms, it would be an electrical brainstorm and what we call a seizure is the physical manifestations of what we see when that happens. Epilepsy, in turn, is when someone has recurrent, unprovoked seizures. So not everyone that has a seizure has epilepsy. Some people can have seizures that happen that are what we call provoked, meaning they happen under certain circumstances, but they never have another seizure again. Those people would not technically fit the criteria for epilepsy, whereas those with epilepsy would have recurrent seizures out of the blue for no reason at all.
So you put it in colloquial terms there, but what is actually happening during a seizure and how long do they last?
Right, so seizures come in many different ways. Classically, we think of a seizure as, classically a grand mal seizure where someone stiffens up, falls to the ground, is shaking. But they can come in ways where they're more subtle, where people have staring episodes, where people have repetitive movements, what we call stereotypic movements, where they do the same thing repeatedly. On average, a seizure can last anywhere from 30 seconds to 2 minutes. And what's happening is the brain is, for lack of a better term, misfiring. And while this is happening, patients can be aware or can have lack of awareness. And depending on where the seizure is located and how big the seizure is, it can manifest as to where they're having a grand mal seizure, or they're staring off into space, what people may call a petit mal or absent seizure. So it just depends on what exactly is going on at that moment.
So how is epilepsy actually diagnosed if not every seizure means you have epilepsy?
Right. So we have different ways to diagnose epilepsy. It can be a little tricky to diagnose, especially when someone has a first-time seizure. We have diagnostic tools that can help us. So, for example, if someone has a seizure, typically we would pursue testing, including an MRI of the brain and an EEG. These tests kind of give us a window into the person's brain and kind of seeing, is this person at risk of having seizures in the future? For example, if they have an MRI of the brain showing that they had a big stroke in the past, conceivably that could be a risk factor for having seizures in the future. If an EEG is showing abnormalities where we see abnormal discharges in a certain part of the brain, that can also be an indicator that this person has a risk of having seizures as well. Still, sometimes it's not as clear cut. So someone can have a first-time seizure with normal testing, and it doesn't necessarily mean that they don't have epilepsy, but at that precise moment in time, we may not have enough information to make that diagnosis. So it's kind of a dynamic process where sometimes we're able to make the diagnosis off the bat. Sometimes we may have to wait for the person to have a second unprovoked seizure, or the testing may show off the bat that person fits that criteria.
What causes epilepsy, and are certain people more at risk than others?
That's a good question. So there's different causes of epilepsy. Sometimes, most of the time, it fits under the criteria what we call idiopathic, meaning we just don't know. But in adults, the most common reason people develop epilepsy is actually stroke. So after a stroke, what happens is a scar tissue can form, and that scar tissue over time can disrupt normal circuitry of the brain and can lead to seizure formation. Other causes can include, for example, if someone has a brain tumor, someone has a head injury and then a scar tissue formation afterwards. Sometimes we can have what we call congenital defects or birth defects, where a patient may have abnormal brain tissue in a certain part of the brain or an abnormal scar tissue. There can be genetic causes as well, oftentimes manifesting in childhood, but it can also begin as well as in early adulthood and even into later adulthood. So there's a lot of research going on into that, but there's different causes of epilepsy.
So are there any ways to prevent epilepsy?
You know, not not necessarily, because a lot of times, it comes down to, when someone has epilepsy, it's either because usually if it's a genetic condition, if it's post-stroke related, if it's a brain tumor issue of some kind. So in some ways, you can't really prevent that. However, there are certain cases where you can prevent having a seizure. So, for example, if anyone could have a seizure if they're intoxicated with alcohol, let's say, if they're abusing drugs, if they're withdrawing from alcohol. So, avoiding situations like that can help prevent a seizure. But in terms of epilepsy, which is recurrent unprovoked seizures, there may not necessarily be a way to prevent that.
How common is epilepsy? Because there are, as you mentioned, a number of different types of seizures. They don't all mean you have epilepsy. So how common is the actual epilepsy diagnosis?
So they've looked at this. It's thought that it's likely underreported, but from what we can tell, it's approximately on the order of about 3% or actually, I would say 1% of the population in the United States. That's about 3.5 million people. And worldwide, it's about 65 million people. So it's a significant amount of the population is affected with active epilepsy. So it is pretty widespread throughout the world.
And how is it treated?
So there's different ways to treat it. It's very individualized for every patient. The mainstay of treatment is anti-seizure medication or anti-epileptic medicines. And there's a variety of treatments that are available nowadays to treat that. Before, back in the 80s and 90s, there were just a handful of medications, but in the past 10 years, there's been an explosion in the amount of medications that are available to treat this. Beyond medicine, sometimes we can offer patients surgical options, whether it be resective brain surgery or what we call neuromodulation, which is devices kind of similar to a pacemaker, if you will, that can help detect seizures and stop them as they come. So now, and of course, there's talk about medical marijuana and other things like that that are now available as well. So there's a lot of modalities we can offer patients nowadays.
How do you discuss all these different treatment options for epilepsy when you're speaking with your patients? And what conversations should patients who might be listening to this podcast or watching it have with their physician if they're not local?
So a mantra that we have in terms of treating seizures is no seizures and no side effects. So that's our goal. So on one hand, we can always try to get patients as seizure-free as we can, but if that may sometimes take 4 or 5 medicines at the cost of quality of life, versus having a patient on 1 or 2 anti-seizure medicines with little or no side effects and adequately controlling seizures. So it's always a fine balance between that. So when I see a patient, I always talk to them about, that's my goal, is to have you maintain your quality of life and independence, but trying to get you seizure-free as best we can. And oftentimes what we do is we mix and match medications that have different mechanisms of action. So, when I see a patient, a big question they have is this medication right for me? And a lot of it will come down to looking at their other medicines, making sure there's no, they're not interacting with each other. That, for example, the patient isn't, let's say, pregnant or childbearing age, because that may affect our choices. And having that conversation that, yes, we want to get you seizure-free or as close to it as we can, but we're also looking to maintain quality of life and making sure that you tolerate your medicines well.
So just to clarify, it is possible with epilepsy to live a perfectly normal, happy, healthy life.
Absolutely. So about 70% of patients can achieve seizure freedom on anti-epileptic medication, meaning 1 or 2 medicines. There are going to be those outliers that take medicines and no matter what they do, still have seizures. But absolutely, it's a common misconception that epilepsy is kind of like the death sentence or a lifelong sentence, when in fact a lot of times there are good treatments now that patients can live perfectly healthy, normal lives.
Now, you mentioned a number of different options, including medicines, but also surgical options. Are there risks or side effects which sway patients one way or another when weighing these treatment options?
Yeah, so our goal typically is, we prefer not to have to go into the brain and do surgery if that can be avoided, because there's a lot of morbidity associated with that. Typically, when a patient fails 2 seizure medicines, they would fit what we call a refractory category, where they're unlikely to benefit from seizure medicines. And that's when we talk more about surgical options. But as you can imagine, with surgery, there's risk involved, infection, wound healing, And also, when you're going into the brain, you potentially may have to resect parts of the brain that are what we call eloquent, or areas that are very important. So if you, for example, if a patient's having seizures coming from the left hemisphere, and you take away part of their brain that's involved in the left hemisphere, most people are language dominant on that hemisphere. It may affect their language, it may affect their memory. So a lot of times when surgery is offered, it's because it's been extensively discussed with a team of other doctors to make sure it's a safe option for the patient. And sometimes it may be the only option or a last resort.
And you did kind of mention this, but I want to circle back. Are there other treatment options when medicines don't work and maybe surgery isn't an option for a patient?
Yeah, so typically if medicines don't work and then resective surgery doesn't work, then there are other options. There's something called VNS, or vagal nerve stimulation, which is basically a device that's implanted in the chest wall with a lead connecting to the vagus nerve up in the neck region. And what that does is it sends signals every minute or two to help stop a seizure, regardless if it's happening or not. There are newer techniques, something called RNS, which is a chip that's basically implanted beneath the skull, and it kind of detects a seizure as it comes. So each patient's thumb signature of a seizure is different, so it can detect a seizure as it comes and only send a signal when it's detected. And then there's something called DBS, which has previously been approved for Parkinson's and essential tremor, but now has an indication for epilepsy, which can be effective as well. And there's other options such as ketogenic diet, but that's used more in children with refractory seizures. There's CBD oil and medical marijuana has a role as well. So there's a lot of options nowadays for patients that, if medicines don't work, they can look into alternative treatments.
But those are usually the outliers where medicines don't work, correct?
Most patients respond to medicines, I would say, but there are some that don't.
And you mentioned the diet. Are there other ways that patients can self-manage when it comes to epilepsy or help reduce their seizures, even if medicines are working and things like that?
Yeah, so very important. So there's a lot of things that we can control to help prevent seizures. I would say the most important would be taking your seizure medication regularly and on time. That's the number one reason people have seizures, is because they forget to take it, or life happens and they're not consistent with it. But that's the number one thing. Staying adequately hydrated, especially now in the Florida sun and the heat. Making sure you get a good 8 hours of sleep every night regularly. So I tell a lot of my patients with epilepsy are younger, so they're in college, they're studying for finals, they're out partying. So there's kind of a big problem a lot of times where they're having seizures, and I ask them, why did you have a seizure? And they're like, oh, because I was up studying for a final, or I was out at a party drinking. So avoiding alcohol, drugs, sleeping, avoiding stress as much as possible. Those are the main things we can do.
You mentioned a few misconceptions about epilepsy, including that it's a lifelong, death sentence, which it's not, or that every seizure is epilepsy. Are there any other common misconceptions when you give, let's say, a diagnosis to a patient or their family, and they have these misconceptions you have to correct?
Yeah, so a big one is there's kind of the stigma with epilepsy and seizures that a lot of times people think it may equate to like a mental illness, when in reality it's actually a physiological basis for it. Granted, a lot of patients with epilepsy have anxiety and depression associated with it, but it is a medical condition, if you will. So that's one thing we talked about. It being a lifelong sentence, but not being a lifelong sentence, but people with epilepsy can lead perfectly healthy lives if adequately treated. They can drive, they can function in society, they can hold jobs. I think another misconception is, when it comes to seizure first aid. So a lot of people, when you see someone having a seizure, we're scared, or don't know what to do, and we kind of have this urge to like intervene or do something when it may be more harmful. So someone's having a seizure, they can have unpredictable behavior. They can become aggressive, agitated without, meaning to do so. But so oftentimes what I recommend patients to do when they're having a seizure or significant others is to clear the area, making sure that everything's safe around the area, nothing can harm the patient. Typically put them on their side. You don't want to put anything in their mouth. So a lot of people do that. They will try to put a mouth guard or something in their mouth to help prevent the patient from biting on their tongue. But if you do that, it may be more harmful. Patients can choke. You may get hurt yourself. So I think it's important to keep that in mind as well. You want to keep the patient safe, but yourself safe as well.
Why is early diagnosis and treatment, along with management techniques, so important for those with epilepsy?
I think it's very important because there's multiple reasons for that. The first being that patients that have uncontrolled seizures can later develop cognitive issues, memory problems, language issues from having all these seizures over time. There's been a well-known phenomenon, something we call sudden unexpected death in epilepsy, where patients that have uncontrolled seizures can actually suddenly die out of the blue for no reason. And it's thought that may be due to something called when you're having a seizure, there's what we call a catecholamine surge. So there's a surge of chemicals produced in the body that can lead to patients having heart attacks and strokes and all kinds of problems from having a seizure. And then patients that have uncontrolled seizures oftentimes have other comorbidities like depression, anxiety, inability to hold a job, inability to drive. So there's a lot of social benefits from having seizure under control as well.
So if someone has had one or more seizures that maybe they haven't sought treatment for, what are the steps to checking for epilepsy and getting that diagnosis if they need to? Should they go to their primary care first? How does that work?
Yeah, so start with your primary care. Definitely want to get in to see a neurologist quickly. And usually the first steps would be, understanding, getting a good history, seeing are these seizures, number one? Do they sound like seizures? Getting the appropriate diagnostic testing, and potentially getting early treatment, depending on what the cause is and what we think is going on.
Is there anything else you want to add for people listening or watching?
No, I think, this is a very important topic. I think we don't discuss it enough. And I think there's a lot of taboo associated with seizures, and, people oftentimes are scared to seek treatment. But I think it's important to understand that, patients with epilepsy are not alone. It's a very common diagnosis. And it is something that I think is very important to get treated, because there are good treatment options nowadays that previously were not there before. And I think, for our community, I think it would be important to recognize that there's a lot of resources out there. There's the Epilepsy Foundation, where, patients without insurance can now get help and get medical treatment for free for seizures, and in our community. And we're going to be developing an epilepsy monitoring unit as well in our hospital. So that's going to be a resource for patients that have uncontrolled seizures to get better diagnosis and treatment options. So I think there's a lot of movement, and it's a very exciting time for our specialty.
Dr. Wolf, thank you so much for
Yes,
answering
thank you
all
so
these
much.
questions today. And as always, we encourage everyone in the community to visit smh.com to get the latest from Sarasota Memorial. Have a great day.